this week on the BackTable podcast.
I think this is a space where there is room, as I mentioned before, for de-intensification, for probably less is more for some of these patients. So we don't need to be getting the huge bites of muscle in these patients. Considering surveillance and fulguration in appropriate patients, I think is very reasonable. And I'm excited to see how the disease space changes over the coming years. And hopefully we're having the patients help guide us in which treatments we really prioritize for them in this space.
My name is Ruchika Talwar, and I'm a urologic oncologist in Nashville, Tennessee. Today, I'm thrilled to be joined by Dr. Kelly Bree, who's a urologic oncologist at MD Anderson Cancer Center in Houston, Texas. Kelly, thank you so much for being here with us today.
Thank you. It's my absolute pleasure.
Before we jump in, why don't you take a moment to tell us about yourself?
So I did my urology training at UC San Diego and then moved here to Houston in 2020 to do my urologic oncology fellowship. And I was lucky enough to be able to stay on faculty after graduating fellowship. So I'm wrapping up almost my third year here on faculty. I'm an assistant professor of urologic oncology here at MD Anderson and the associate fellowship program director. Initially, when I started practice, I was doing a little bit of all of urologic oncology. And over the last year, I've really subspecialized just in urothelial carcinoma. And so I'm really thrilled to be here today talking about intermediate risk non-muscle invasive bladder cancer.
Well, we're excited to have you. So we'll be focusing on that nuanced space of intermediate risk bladder cancer, throughout the course of this episode. So let's just start off by, having you walk me through how you explain risk stratification to patients who are diagnosed in this intermediate risk space.
Yeah, so it's a great question. I think our guidelines, the various guidelines make it a little bit confusing because it's not very clear which patients really fit into the intermediate risk group. There's lots of nuances depending on which guidelines you're looking at to help stratify which patients really qualify for that group. In my practice, patients that have a small, solitary, low-grade tumor, less than 3 centimeters, they are low-risk patients. Any patient that has any component of high-grade disease, and this differs some from the guidelines, I consider high risk. And I think many of us that are practicing urologic oncologists practice that way. And so then for the intermediate risk group, it's really all these patients that have multifocal, recurrent, very large, low-grade TA tumors. It still is quite a heterogeneous group. But I think different than some of the guidelines, including the AUA guidelines and the newest versions of the EAU guidelines, which do incorporate some small high-grade tumors into that intermediate risk group. When I counsel patients and treat patients, if they have a high-grade component, they're treated as high risk.
Yeah, and I think that's right. I think a lot of times we tend to group patients into that high-risk category just to be on the safe side. I'm curious, though, do you feel that we're a little too aggressive in that regard? Part of this is challenged by the fact that there's not a lot of current options for intermediate risk, and it, in the setting of a BCG shortage, it gets a little tricky. But, I kind of get that sense that sometimes we're overly aggressive. Tell me your thoughts on that.
For sure, especially for patients with low risk and intermediate risk disease, these patients that have low grade TA tumors, I think there's a lot of room for us to de-intensify the treatment, the surveillance. Many of these patients are in their 80s, 90s with a lot of other competing comorbidities. And for a patient that has an occasional low grade TA or a few small low grade TA tumors, it's exceedingly unlikely that that's going to shorten their lifespan in any way. And so I think there's a lot of room for moving towards surveillance for some of these patients, for considering clinic fulguration for some of these patients. And some of it's also driven by patient concern and anxiety. So not to say that none of these patients shouldn't be getting treated, but I definitely think there's room for us to be doing less for some of these patients.
Yeah. What specific factors influence whether you pursue intravesical therapy or, like you mentioned, manage those patients conservatively?
Yeah, so I think there's a number of risk factors, and I think the IBCG has done a nice job of kind of describing some of the risk factors for patients that are going to have increased risk of recurrence and progression. And so patients with multiple of those risk factors are more likely to offer some sort of intravesical therapy to. Patients that have multifocal tumors, frequent recurrences, multiple within a year, large tumors. So those would all be reasons that I'd be more likely to recommend some sort of intravesical therapy. Some of this also, like I said, is really needs to be more patient-centered. So the 90-year-old lady who has 3 small, low-grade appearing tumors that are a couple millimeters in size, though she might have multiple risk factors because she has multiple tumors, having her come once a week to get intravesical gemcitabine when she's also dealing with a recent hip fracture and everything else in the transport. I don't think we're really moving the needle on, certainly not moving the needle in survival, and probably moving the needle in the wrong direction in terms of quality of life.
Yeah, definitely. So along those lines, you mentioned gemcitabine. What intravesical therapies do you currently consider for intermediate risk patients who may be, those types of patients that have factors that would push you to doing something?
Yeah, so for most of my intermediate risk patients that have low-grade disease, intravesical gemcitabine is really my first-line treatment option. Occasionally in patients with multiple different risk factors, considering BCG, but typically I would do gemcitabine first and reserve BCG for patients that are refractory to that. I also think it's a great space to consider enrolling patients on clinical trials, especially since this is not a disease that's likely to shorten their lifespan at all. And so any new agents that can kind of prolong that time between recurrences would be wonderful. So we have the Pivot 006 trial open here with cretostimogene, and so I also will enroll patients on that trial currently, but typically gemcitabine are talking to them about a trial.
What other new agents, on the horizon excite you? What are things that you're paying attention to in this space?
Yeah, so I think it's, in general, a super exciting time to be in bladder cancer. I think the TAR devices are really exciting. There's obviously the TAR-210, which is erdafitinib for patients with FGFR mutations. TAR-200 with gemcitabine, obviously, has mostly been studied in the high-risk space, but I think for this patient population could potentially be really amazing, especially with that prolonged release and the opportunity to give some chemoablation to these really small 1 or 2 millimeter tumors that we see. As I mentioned before, cretostimogene, so looking at the new oncolytic adenoviruses and where they fit into this treatment paradigm. UGN 102 is another, reverse thermal mitomycin, again offering chemoablation. So kind of moving away from having to take patients to the OR every single time they have a recurrence for a TUR, and what treatments can we be giving in clinic to minimize the number of times we need to be taking these patients to the operating room.
Yeah, definitely. And you alluded to this earlier. The thing I think about in that space with chemoablative therapy is avoiding anesthesia in patients who are high risk. You mentioned the older patients, the patients who may have concurrent comorbidities, the elderly patient with the hip fractures, all of that. So I agree with you. Super, super exciting space to be in. Now, when it comes to intravesical therapy and actually also serial cystoscopies and TURBTs, I want to spend a little time talking about the quality of life changes that occur after bladder cancer. I think especially those of us who are urologic oncologists, but there's obviously urologists in the community who treat this day in and day out. We center our quality of life conversations on the high-risk patients, the patients we're talking about cystectomy on, but this population, it's intense, after you get this diagnosis, it really can be life-changing. So tell me a little bit about how those quality of life conversations go for you and counseling these patients. What are some things we should really be emphasizing?
Yeah, and so when I diagnose a patient or a patient's coming to see me in consultation for a second opinion after a diagnosis of a low-grade TA tumor, I typically tell them that that this cancer is not something that will shorten their lifespan, and that the only part of this that could shorten their lifespan is like the anxiety and stress related to all the treatments that we're going to discuss with them and offer them. And I think that I truly like believe that in my heart, the chance that these patients have meaningful progression it's not zero, but it's very, very low. But for many of these patients, it means interactions with our clinic and the healthcare system 20, 30 times over the course of a year, which has financial toxicity, emotional toxicity. I mean, the list goes on, not to mention how the discomfort they might have with some of those treatments.
Yeah.
So I think it's really important to kind of set that framework, and so that you can have a real individualized discussion about how aggressive people want to be with their treatments. I mean, I also have patients telling me that they like can't sleep at night because they're worried about the tumor coming back. And so in those patients, coming once a week to do the installations and making sure that we biopsy when things come back makes more sense than the patient who, like I mentioned before, is 90 years old and has a bunch of other things going on, and this is like the least of their worries. And so then in terms of the treatments, when we talk about TUR, I think especially for these patients that have a known history of low-grade tumors, they have recurrence and you've made the joint decision to take them for a TUR, I think it's important that we don't need to be doing super duper aggressive TURs in these patients. These aren't patients with high-grade T1 disease, and we need to be getting great bites of the muscularis propria. We don't need to be even getting muscle in these patients. So removing the tumor to get pathology and ensure continuing to surveil or doing intravesical gemcitabine is the right move, I think is okay. But we don't need to be doing super aggressive TURs that are going to risk perforation and leave patients with bladder spasms that are debilitating for weeks. With respect to the intravesical treatments, I think in general, I have found that most of the patients tolerate gemcitabine quite well, much better than the BCG treatment. And so but the biggest issue is the frequency of it and issues with transport in some of these elderly patients. I have real conversations with them about what the treatment course looks like and how frequently and how many number of visits they'd really need to be making to our clinic over that first year or so to make sure it aligns with their treatment goals.
Yeah. And you mentioned this. I mean, I love that you called out the fact that we have to think about what our surgical goal is during TURBT.
Mm-hmm.
You know, again, it's one of those like simple procedures we take for granted.
Yeah.
I, admit that maybe we're not always as thoughtful as we should be about thinking about, okay, given this location, do I really need to be aggressive to get this whole thing? Because you're right. Patients have debilitating bladder spasms, side effects. And we take that recovery after TURBT really for granted. It's a same-day procedure. Tell me, how do you prepare patients for recovery after TURBT? I want to get, really practical here. Again, because where do these conversations live? I've never, outside of my residency training, I very rarely heard someone, go through how we should be doing adequate TURBT counseling, although we spend a lot of time talking about preparation before radical cystectomy.
Yeah.
And there's a lot of evidence that recovery actually takes a lot longer than we anticipated originally. So tell me, let's get real practical here. How do you prepare your patients?
In patients with low-grade tumors where I don't think I'm going to need to be getting muscle, I don't necessarily tell all of them that they will need a catheter, but many of my patients, if I'm telling them that we're going for a TUR, I tell them that to plan to have a catheter for a day or two after the procedure, especially patients at its initial diagnosis and we're trying to get deeper bites of the muscle. I give all of my patients a prescription for Lebsin beforehand and have them pick that up beforehand so they have that with them and their family has it with them as they leave the surgical facility. And I tell people that for the first couple days after the procedure, they're going to feel like they frequently need to pee, even though the catheter is in, to use the Lebsin as needed. I finally found a local pharmacy that has B&O suppositories again. So for patients we still don't have it here in the hospital, but so for patients many of these patients had been through multiple TURs before. So the patients where they know that they're just miserable after, even without an extensive resection, getting them set up with that ahead of time. So they have it at home when they need it. And then I tell them that for the next couple weeks, urination is not going to be completely back to normal. Having more frequency, urgency, especially if we're doing a really big resection, is unfortunately kind of par for the course. Trying to avoid a lot of things like caffeine that are going to just further exacerbate their temporary worsening of urinary frequency. But I think especially for this patient population where we don't need to be going crazy necessarily with the TURs, I think we need to be really thoughtful about it because it does have real quality of life impacts, especially on our patients that are still trying to work. Maybe they're taking the day off for the procedure and then have to go back to work. I think we could do a better job of being more thoughtful about the procedure itself and how we prepare them for sure.
Yeah, and there's been a few studies recently that I found interesting. One of them, that I recall was one of the former Fox Chase fellows during his research here at Fox Chase had published Marshall Strother. He's now at Oregon at OHSU. But, I remember reading one of his studies mapping out the patient journey after TURBT and just thinking like, wow, we really underestimate what people are experiencing, after this simple procedure.
Yeah, and I also spend a lot of time talking to them about like how normal hematuria is after. We have a lot of patients that are traveling from far away to come here. They get their TUR and then they go home, and as the scab falls off a week or two later, get panicked calls, or at least initially when I started, that they thought a tumor had grown back and they were bleeding. And not that it takes necessarily as much time as a cystectomy to prepare them for, but it does require, we take it for granted because on our outpatient surgery days, we're doing like 10 of these a day and it's just another day in the office. But for each of these patients, especially when they haven't had it done, it can be really, at least temporarily, life-changing. And then additionally, talking to them about pretty significant dysuria. Unfortunately, the resectoscopes are not the most gentle instruments that we use. And so kind of letting them know that some of that is normal. And for patients that have really struggled with that before, or that I have to do a lot of dilation, I'll be sure to give them Peridium after too.
Yeah. You mentioned earlier that in some patients, you'll talk to them about in-office cystoscopy and fulguration. And so we're seeing that done more and more commonly. A lot of offices have nitrous and will consider, using nitrous. So it sounds like some people do it without nitrous too. So I'm curious, tell me a little bit about, your practice's experience with in-office cystoscopy fulguration.
Yeah, so we don't use any nitrous in the office. So for the patients that we're offering fulguration to, we do it awake. We give them lidocaine UroJet in the urethra just like we would for normal cystoscopy. But patients in general tolerate it very, very well. I think obviously you don't want to be doing it for a 3 or 4 centimeter tumor where the bug bead touches the surface and you can barely do anything more than just cauterizing the surface. But for the small tumors, the ones that are less than a centimeter, I think it's a really reasonable treatment option. And obviously is patient dependent. I have some patients who, if they have a couple small 3 or 4 millimeter lesions, would rather just surveil and do nothing. And then I have others that get anxious when they see it on the screen and want something done right away. And so it's, I think, a really individualized decision, but the patients that I've done it on have tolerated it great just with urethral lidocaine without anything else.
And, I'm curious what your criteria is for in-office fulguration. What kinds of tumors are you fulgurating versus what kind of tumors are you saying, hang on, we should go to the operating room for this?
Yeah, so I mean, I would only do it for patients that have a known history of low-grade tumors in the past and have a tumor, again, that looks low-grade. We will typically send, I obviously won't have the cytology results at the time, but we'll send cytology as well to ensure that the tumor that appears low-grade actually is low-grade. But a patient that has a few, I mean, not someone that has like an entire bladder full of tumors, but a few tumors, I'd say they all need to be certainly less than a centimeter. Those patients, again, with a history of prior low-grade tumors, I would be willing to do fulgurations. If when we have them come back for their next cysto in 3 or 4 months, their bladder has exploded and has a bunch of other tumors, then I think we have a conversation about when to actually go and do biopsies. Occasionally, we'll do small biopsies in clinic too, again, just with the urethral lidocaine and cauterize after. But I think, again, someone that's had a history of really just low-grade tumors, if it has that appearance, either surveilling them or offering fulguration is reasonable.
Yeah, you mentioned that you do in-office biopsies too, so that may answer my next question for you. But, as you were talking, I was thinking, I wonder what that time frame between tissue diagnosis and, let's say, they eventually get a recurrence. What's the time frame between, the time point, the initial index diagnosis with tissue versus the next time we're going to need to get tissue? You said that you may just take it in the office, you're going to send a cytology, but tell me your thoughts on that.
Yeah, so I think I don't have like a hard and fast absolute cutoff, and some of it again is dependent upon a lot of patient characteristics. So our patient, like our 80 and 90-year-old patients with a lot of other comorbidities, where it's unlikely to be something that's really shortening their lifespan, I'd have a much higher threshold for, again, treating this conservatively in clinic versus young and but I would say patients that are having really rapid recurrence of tumors, every time we're looking in their bladder, we're seeing something. Patients that are having large tumor recurrences, again, a bladder full of recurrences, I think those are reasons that we need to make sure we've had recent upper tract imaging and there's not some lesion in the upper tract that is seeding the bladder, and to get tissue to ensure this really is still just a low-grade tumor that's poses a low risk of progression, and being more conservative is still safe.
Let's circle back a bit to the counseling that we were talking about earlier. The one thing that we haven't touched on yet are the resources that are out there for patients. I personally love as a urologic oncologist, there's advocacy networks for almost every cancer or foundations that have resources online, Urology Care Foundation being one of them. What kind of resources do you recommend to your patients? And also, what do you find that they're looking for? Like, are patients looking for videos, written resources, podcasts? Like, tell me what your experience has been.
Yeah, and specifically for this intermediate risk population.
Yeah.
I would say, my favorite resource for all of my patients with bladder cancer is really the Beacon website. I think that they have really great resources for patients to read, but also all their, like, the patient portals where they can go on and post questions and read real people's experience about the various treatments, I think is invaluable. And you can spend all day telling the patient what to expect about the treatment, but most of us that are urologic oncologists haven't had non-muscle invasive bladder cancer and actually been through all the catheterizations and cystos. So I think it's easy for us to tell someone what it's like without truly appreciating what it's like. We also, it's starting next month, but we have a bladder cancer support group here that is starting, and we're gonna have in-person meetings allowing patients to interact with other bladder cancer patients throughout the entire spectrum of disease. And I think I haven't found it quite as frequently in this patient population as the patients with high-grade disease that are requiring cystectomy, that they really want to sit down and have those conversations in person with people. But I don't know that I've actually asked explicitly. I will ask the bladder cancer patients that are requiring cystectomy, because it's such a big life-changing procedure, if that would be beneficial. And I probably am not doing my due diligence and haven't actually asked these patients what they need to make the decisions. But Beacon is normally where I start for most of them.
Yeah. And I just think this specific space is a tough one because they're not, as you mentioned, the high risk, but they're not the low risk either. And so, we're either sometimes being a little too aggressive. Sometimes I wonder if we're not, doing as much as we can, and perhaps they're at higher risk for recurrence, as you alluded to earlier, probably not as worried about serious progression, but certainly recurrence. And I definitely tell my patients, this is going to be an annoyance. Like, I'm sorry, it's going to be more of an annoyance than anything else. But you're right. I do think there's more we can do to understand this disease space. It's sort of like the ugly stepchild of non-muscle invasive bladder cancer.
No, and I think as more and more agents get approved in non-muscle invasive bladder cancer, I think it's going to be more important than ever that we're incorporating patient-reported outcomes as we try to decide which agent do we use next after gemcitabine. Many of them are very costly and have similar, although not as many have been tested in this space as the high risk and BCG unresponsive space, but they all have similar response rates. So as we're trying to select, really asking our patients what is most important. Is it having agents like nadofaragene where they can come once every 3 months versus once a week? I think for a lot of our patients, if given an option, they would choose a dosing treatment like that compared to weekly installations. Or is it what's going to give them the least bladder spasms afterwards?
Or what can avoid a trip to the operating room,
Exactly.
and,
Yeah.
And I think it's tough. You alluded to this. A lot of the agents that you mentioned are specifically for the high-risk space, and there really hasn't been much. You alluded to UGN 102 as a potential agent, and obviously as these new trials give us insight into drugs that were originally used for high risk, we will hear more about their utility in intermediate risk, of course. But it's just still so nebulous, and I'm excited to see what's on the horizon with these agents, and at the same time, want to recognize ways we can do better today in our discussions with our patients as they start this intermediate risk non-muscle invasive bladder cancer journey.
Yeah, no, I agree completely. And I think the differences in all the guidelines and how we define intermediate risk disease also further complicates is that as we try to compare these new agents, and we're all using different definitions of what this disease even is. So I think there's lots of room for improvement and research in this space, and really incorporating the patient voice, probably more importantly than almost any of the other disease spaces within bladder cancer.
Yeah, I couldn't agree more. As we wrap up here, anything else we haven't covered about intermediate risk bladder cancer that you want to touch on?
I don't think so. I think just the big takeaway I'd have for everyone is that I think this is a space where there is room, as I mentioned before, for de-intensification, for probably less is more for some of these patients. So we don't need to be getting the huge bites of muscle in these patients. Considering surveillance and fulguration in appropriate patients, I think is very reasonable. And I'm excited to see how the disease space changes over the coming years. And hopefully we're having the patients help guide us in which treatments we really prioritize for them in this space.
Yeah, absolutely. I couldn't agree more. I think first and foremost, it's critical that we capture the patient voice as we, have these conversations, incorporating shared decision-making and figuring out a path forward. But it is a delicate balance between being aggressive versus being conservative, and understanding what their specific goals are. So I couldn't have said it better myself. We really appreciate you taking the time to chat with us today. Thanks so much.
Yeah, it's been my absolute pleasure. Thank you for inviting me.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.